अरे तू परत गेला.
नहीं, I am here only.
You can start, ma'am.
We'll start.
अदृश्य होऊन जातो काय केव्हा केव्हा.
Good morning to all dignitaries, faculties, and all delegates. I, Dr. Manjusha Giri, Vice President of IMA Nagpur and convener of today's CME, Close the Care Gap, welcomes you all on behalf of Indian Medical Association, Nagpur, and Rashtrasanta Tukadoji Maharaj Regional Cancer Hospital and Research Center, Nagpur. As we all know, World Cancer Day is celebrated on 4th of February every year by an initiative taken by UICC, that is Union of International Cancer Control. According to WHO, the cases of cancer has been increasing since 1990, and if it continues to happen, there will be more than 16 million cases by 2040. This year's theme for World Cancer Day is Close the Care Gap, to encourage the people to bring in some change, whether it is minute one. And the CME is a part of this awareness to reduce the impact of cancer on lives of people. Here, I request Dr. Sanjay Devtare sir to welcome the gathering, President of IMA Nagpur. Over to you, Devtare sir. Sir, unmute कीजिए.
हाँ हो गया. आ गया अभी वॉइस?
Yes, sir.
A very good morning to all respected dignitaries, speakers, moderator, panelists, and a very intelligent audience. On behalf of IMA Nagpur, I welcome you on this sunny Sunday morning for CME on Close the Cancer Care Gap. On the occasion of World Cancer Day, that is on 4th of February, we celebrate every year to make awareness about the cancer, which is rapidly spreading. BK Sharma sir and Dr. Manjusha Giri has taken up a lot of pains, lot of effort to organize this CME, and I must congratulate them for the success of this CME. I am also thankful to Dr. Manisha Rathi, Madam, MMC Observer, and the MMC for allowing us to give the credit points. Since last many years, due to Dr. BK Sharma sir's effort, RST has become inseparable part of the IMA Nagpur. Please keep this association going on. Thanks and congratulations to RST and their staff for doing a commendable job in cancer care. Jai Hind, Jai IMA Nagpur. Thank you. Over to you, Manju.
Thank you, sir. Really, RST is doing incredible job in cancer care. Our next part of the CME is, I request Dr. BK Sharma sir, who is Vice Principal of MSBT, students of PGMLT and PGDRTT in RST Regional Cancer Hospital. He is Principal Investigator of Population-Based Cancer Registry, currently working as Honorary Consultant in Head and Neck Department, and he is ex-Joint Director from 1990 to 2020. Sir, please explain us about the theme of today's CME or World Cancer Day.
Thank you very much, Manju. Good morning to all the viewers, all my seniors, respected seniors, all my colleagues, all my juniors, members of IME. First of all, my thanks to the dynamic president, Dr. Sanjay Devtare, and the Dr. Sachin Gate, who is the secretary also, and giving me this opportunity to have this CME on the Close the Cancer Care Gap. And I must tell first, Dr. Manjusha Giri, who is Vice President, taken a lot of effort to arrange for this CME. And also, thanks to the Manisha Rathi, who is our MNC observer. Now, friends, this CME, actually, it is already announced by the WHO for 3 years to just make close the cancer care for the cancer patient. The idea is that in that what we had to do it, we had to first diagnose the disease, then we had to do the diagnosis, then treatment and follow up. And after this, we should also help our cancer patient for their monitoring, which they have difficulties also. Not only that, we also time to time follow our patient also, and this we have to care this. And this way we can give a best to best service regarding all the availability of from our hospital. So thank you very much once again, and you enjoy this CME.
Thank you, sir. Thank you for explaining about theme in brief. And I invite Dr. Kartar Singh, sir, for his words of wisdom. Dr. Kartar Singh, sir, is MD in Radiation Oncology from Jabalpur, and he is at present working Director of RST Regional Cancer Hospital till date. And I invite you, sir, for your words of wisdom and blessings to the CME.
Thank you, ma'am. Good morning, everyone. Today we are having discussion on a theme given by UICC, Close the Care Gap. We will be having 2 lectures and a panel discussion. On behalf of Rajchandra Tuklji Maharaj Cancer Hospital, I welcome IMA President Dr. Sanjay Devsade, our Secretary, IMA Secretary Dr. Sachin Gathe, Vice President Dr. Manjusha Giri Madam, MMC Observer for this CME Dr. Manisha Rathi. I also welcome our eminent speaker of today's topic, Dr. Anirudh Bag and Dr. Randive. I welcome the panelist team, moderator Dr. Kanesar, panelist Dr. Prasant Roke, Dr. Mayur, Dr. Mukesh Bang, Dr. Satya Sapre, Dr. Pachel sir. As everybody know, Rajchandra Tuklji Cancer Hospital is 47-year-old, and in the year 2018 we got TCCC, Tertiary Cancer Care Center recognition by Government of India. So all these recognition goes towards the theme, and the theme is Close the Care Gap. RST Cancer Hospital is busy in closing these care gaps, whether they are at the social level, whether they are at the awareness level, whether they are at the diagnosis or the treatment or the after treatment facility. So we are, even in the time of pandemic, when most of the hospitals have reduced their OPD work up to 25-30%, we have given this care to the patient in the 90% of the cases. Our average is 500 patients per month, and every month in this whole year of pandemic, we have registered up to 470, 460 patients per month. So we have given a good care during this pandemic period. And in this gap, we are having 2 departments, HBCR and PBCR. They are working to find out what are the gaps where patients are having lacking or the lacuna in their awareness, diagnosis and treatment. We are also filling this gap through our scheme of MJY and PMJY, and this gap is due to financial reasons, and government is helping us to fill this gap. Hospital facilities, every year we are adding new treatment facilities. In the year 2018-19, we have introduced brachytherapy for the cancer patients. In the year 2020, October 2020, we installed one new linear accelerator where we are treating up to 120 patients per day, and we are treating till 1 a.m. in night. And for this closing the gap, we are also introducing one 250-bedded hospital, upcoming hospital with all facilities for the cancer surgery, cancer chemotherapy, and cancer radiotherapy. I welcome all the audience to today's topic. Over to you, madam.
Thank you, sir. A great work, commendable work done by RST Cancer Hospital. And you are really closing the gap between patient and treatment. Thank you so much, sir. Here I request Dr. Sachin Gathe, Secretary of IMA Nagpur, to propose formal vote of thanks. Over to you, Dr. Sachin Gathe.
Yes. Thank you, Manjusha madam. On behalf of IMA Nagpur, I am proposing a formal vote of thanks. So this CME close the cancer care gap, which is based on the World Cancer Day, which was happened on 4th. I thankful to Cancer Relief Society, RST Cancer Hospital and Research Center for collaborating with IMA Nagpur to organize this CME. And it's very important CME. I'm thankful to the speakers who are well known. The WAG with co-PI, and they are going to talk on the important topic of cancer registry, which is very important. This is not technical, not therapeutic, but it is very important to make a decision on the planning for the cancer care program. Dr. Nandive is going to speak on how does the cancer registry work and how will it help in the campaign. And Dr. Aniruddha Wag is going to speak on how to reduce the gap in cancer care. Very important topic. After that, there is a excellent panel discussion. All the eminent faculties, and the panel discussion topic is how do I close the gap while caring the cancer patient. We all know RST is working for this cancer care, especially for the downtrodden people from the society, helping this long. Panelists are Dr. Sriram Kane, well-known medical oncologist, Dr. Mukesh Bang, medical oncologist, Dr. Sapresar, head and neck surgeon, Dr. Mukesh sir, radiation oncologist, Dr. Pachel sir, well-known anesthetist, and Dr. Daigon, he is a gynecologist. They are going to speak on how do I close the gap while caring the cancer patient. I thank you to all these panelists for giving their precious time and guiding our audience. Also thankful to RST Director Dr. Katar Singh, Additional Director Dr. Sirmanwar sir, the well-known head and neck cancer surgeon, former Director of RST Cancer Hospital, for advisor Dr. B.K. Sharma sir, and today's convener, our very own Vice President Dr. Manjusha Giri. Thank you. And the last, the audience joining in the large number, almost more than 100 audience already joined, and our digital partner DigiShield, Dipe and Piyush. Thank you very much. I will hand over mic to our convener, Dr. Manjusha Giri. Over to you, ma'am.
Thank you, Dr. Sachin Gathe. And we also thank Dr. Manisha Dhut, Madam, convener of MMC Observer of today's CME, for sparing her precious time. Now we will move to our first topic, and our first opening batsman is Dr. R.B. Randive. Dr. R.B. Randive, sir, Piyush, Mr. Piyush, please share slides. Meanwhile, Mr. Piyush? Piyush? Mr. Piyush, anyone from DigiShield? Just a second. I think there is some issues. So our topic is, our speaker is Dr. R.B. Randive sir. He will speak on how does the cancer registry works and how will it help. Dr. Randive sir has passed out MBBS from Government Medical College Nagpur, 1982 batch, and he has joined Coal India Limited in 1984 as medical officer. He has worked as occupational health in charge for 10 years. After glorious service for 32 years, retired in 2016 as chief medical officer in 2016 and joined as a deputy medical superintendent at Rashtrasanta Tukadoji Cancer Hospital from 2018, and he is also research scientist from 2019. Over to you, Randive sir.
Yes, madam. Thank you, madam. Share the, hello. Share the slide.
Yes, sir. Slides are shared.
Yes. Oh, रजिस्ट्री का नाम सुने हैं. रजिस्ट्री जनरली घर की होती है, फैमिली रजिस्ट्री जनरली प्लॉट की होती है, पर यहाँ रजिस्ट्री जो है ये कैंसर वर्क की हो रही है. रजिस्ट्री के लिए हमारे पास दो कैंसर रजिस्ट्री प्रोग्राम, the hospital based cancer registry HBCR of RST Regional Cancer Center Nagpur started in 2012 under the network of Indian Council of Medical Research ICMR. The HBCR of RST collects the information on cancer patients attending RST Cancer Hospital. We got the approval for PBCR, Population Based Cancer Registry, for Savner and Nagpur Rural. Nagpur Rural, without financial support from ICMR, NCDR Bangalore, on 8th May 2019. Population-based cancer registry systematically collect data on all new cases of cancer occurring in a well-defined population, that is a resident of particular geographical region, and one that must be for 1 year at least resident area, from multiple sources such government hospital. We collect the data from multiple sources: private hospital, government hospital, nursing home, imaging centers, hospitals, and other registrar of birth and deaths. Next. The primary purpose of hospital-based cancer registry is to contribute patient care by providing readily accessible information on the patient with cancer, the treatment received and its result. Data collection is done by the individual registry using a standard common core form. The information in this form mainly consists of pattern, patient identification and demographic information, details of diagnosis, the clinical stage of disease, and the broad type of treatment given. HBCR collects the information of cancer patients from files of RST and submits the forms online to NCDR Bangalore, that is National Center for Disease Information and Research. We are filling the core forms for the cancer and post form, that is pattern of care and survival studies for head, neck, face, breast, and cervix cancer. It is online application and it can inspect share, check, and analyze the data. Next. The objective of HBCR program is to assess the patient care, to use the data for clinical research, to assess quality of hospital care and cancer services. It helps to improve and plan hospital facilities. It generates reliable data on magnitude and pattern of cancer in covered area. It is useful to undertake epidemiological studies based on results of registry data. Next. Cancer incidence. In Australia, it is highest, that is 400. First slide, 412. Overall lead, and in India it is 156, and worldwide it is 212. Overall leading sites are for world is breast cancer, that is 29%, lung, bronchus, and pleura it is 11%, prostate cancer is 7%, colorectal cancer almost 7%, skin cancer 3.3%, cervix utera 9%. In India, 14 lakh population, male is 55% and female 45%. Oral cancer, that is the leading cause in 39% of patients suffering from oral cancer. Breast cancer is 13%, cervix cancer 10%, lung cancer it is 7%, colorectal cancer 6%. That is our findings. Next. Cancer diagnosis and treatment. Diagnosis by physical examination, laboratory test, imaging test, and biopsy. Treatment. The most common treatments are surgery, chemotherapy, radiation, and other options include targeted therapy, immunotherapy, laser, hormonal therapy, and others. And new is to be added. Next. Basic tenet is disease do not occur in random. Disease have causal initiating factors. Diseases can be adequately managed and prevented. Next. Risk factors for development of cancer is mostly tobacco. Very rampant use of tobacco we see in the society. It is mixed with tuna and other exposed to radon. Excessive consumption of alcohol, family history of cancer, excessive sunrise exposure, human papilloma virus. This is due to infection of human papilloma virus, human and HIV, and hepatitis B virus. Age group, generally it is found in 40 to 65 years of age. Gender is 53% male and 47% females are affected. Poor diet, that is anemia. Mostly patients we see basic is anemia. We see all these condition in each and every patient almost, and poor health. Some patients have overweight and obesity, physical inactivity of the patient, not following normal daily living pattern of life for activity and sleep. That is due to mostly in second shift or third shift wise pattern of the duty. Next. This is a slide seen. This is for Manisha Koirala. It is she had suffered from cancer ovary. She has undergone treatment, and basic here I would like to suggest one point was her complaint was only belching and bloating, but could not found the she could not say that she is having heaviness in the abdomen, and that was the main concern. However, she undergone treatment at foreign and due to surgery, and after that she underwent chemotherapy and she is completely all right. Next. This slide is for Ginsburg, madam. The Supreme Court Justice announced that she had cancer-free in 2020, but here is receiving treatment for pancreatic cancer that summer. Ginsburg had been treated for cancer 5 times throughout her life. You see the including cancer colon since 1990, surgery for early stage pancreatic cancer in 2009, and surgery to remove cancer in lung at 2018. Ginsburg died from pancreatic cancer in September 20. The point is, she has almost suffered 20 years with cancer. 5 times she had suffered from cancer, and she has undergone treatment and lived 20 years with the cancer stage. You see, this can happen. Is it possible in India to undergo treatment for 20 years? Next slide. This is Sanjay Dutt, cancer survivor of cancer lung. He has initially said, "Hey Bhagwan, how it has happened to me?" But you see his normal living pattern of life. Since beginning, young days, he was addicted to some drug, and almost many times throughout his life, he has consumed alcohol also, and he has undergone treatment at foreign with carcinoma lung. But basically, I would like to see regarding this slide, the main intention of me is that after the COVID pandemic, the trend of cancer lung, we will see after 10 or 20 years duration, the cancer lung incidence will be more prevalent in India or worldwide, and treatment will be depend on many things. Next, this is prevention of cancer. Here some points are mentioned. Avoid smoking. Avoid smoking. No alcohol throughout life, or eat healthy diet. Be physically active. Go for a vaccination. And for persisting abnormal complaints, go consult the doctor. People-centric diagnosis and treatment. No one is left behind with these stages of throughout life. Health literacy program, stigmatization. Totally, it should not be seen that there is stigma with those suffering from cancer. Stigma is not, and definitely stigma is not attached with this cancer stage patient. To minimize the risk, to health promotion, to include healthy lifestyle, we advise to include healthy lifestyle. Next. And the main basic problem is how to control the world population. And who will control it? Human beings will control, or natural calamities will control, or unnatural calamities. Here we mention the accidental death also, and or pandemic corona. Who will control the population worldwide? Next. Here, you see this slide is shown for pot belly abdomen. You see this girth abdomen is very high, and that is the reason he may be suffering from many diseases, diabetes, hypertension. Next, and do exercise to keep healthy lifestyle, as this gentleman is doing the exercise to keep him healthy. Next, this gentleman is doing exercise to keep healthy. Next, and to close the care cancer gap, we think that is bilateral. Patient should go to the doctor to appropriate treatment, and there should be no dropouts. Okay. Next. Thank you.
Thank you, sir.
Thank you, madam.
Thank you so much, sir. Such an informative and lucid talk by you. And there is one sad news from social media that Bharat Ratna awardee Nightingale of India, Lata Mangeshkar ji passes away, and we pay condolences to her. Her voice will remain always in our mind and soul and years together. Our next speaker, to our participants, there is one request. If you have any question, so please put them in your chat box. Our next speaker is Dr. Aniruddha Vag, and he is going to speak on close the care gap.
Good morning, everyone. Good morning, everyone. It gives me immense pleasure to give talk on Close the Gap in Cancer Care, which is UICC World Cancer Day theme. And as we all know, World Cancer Day is observed on Feb 4 to raise awareness, improve education, catalyze personal and government actions to save millions of deaths. Further, it seeks to reimagine a world where access to life-saving cancer treatment and care is equitable to all, no matter who you are or where you live. So when it comes to cancer, many of us are even denied basic care, despite the fact that we live in a time of awe-inspiring advancement in cancer prevention, diagnosis, and treatment. This is equity gap, which is costing lives. The gap affects everyone, and we can close the gap. So this is a picture worth millions of words. And this year's theme focus is to focus on inequalities in distribution. These barriers could be financial, as we can see the gap between rich and poor. These gaps could be cultural, educational, socio-economic, gender, geographical, and age. So what is inequity and what is inequality? Equity is about giving everyone what they need to bring them to the same level. UICC has launched a 3-year campaign to create equitable access to cancer care with the theme Close the Gap in Cancer Care, first in 2022 and 2023. The first year they have dedicated to only recognize the inequalities, what are the inequalities in cancer care around the world, and make them equitable. So this is a picture which is showing what is the exact difference between equality and equity. In equality, you give them opportunities, but they may not be equal. And in equity, you can see how they are brought to the same level so that everyone can enjoy the benefits. So what is equity? This is about you, this is about me, this is about everyone. Like in developing countries, many things are denied and many things are not accessible. So this is some data which are taken from UICC website. They have said that in the United States, the white women are far more survival rate than the black woman. Then in New Zealand, Maori tribe is having more likely to die from cancer because of lack of health facilities and access to that. Even in cervical cancer and childhood cancer, there are much more mortality in developing countries compared to the developed countries. And also the elderly population. The elderly population is susceptible. One thing, they cannot go to the cancer care or cancer center on their own. Then again, in developing countries, economic deprivations. And as you can see, other populations which are refugees, transgender, rural, they are also susceptible. Because any population which is denied of equal rights to other population is susceptible to deprivation of the facilities. So how we can tackle this? So what is the answer? The gap can be closed. The progress is the only key. The education, the progress, the improving of socio-economic status, awareness and screening are the ways. These are the few examples which have been taken recently to improve the cancer care. In Nigeria, the nation developed a CBC Cancer Center digital tool, Oncopady, which is helping all the population, rural, urban, and bringing uniformities in the cancer care. Second, in Canada, there are several NGO organizations collaborated across the sectors to help poor, middle class, and bringing everything closer and helping them for a treatment. Then, as we all know, this has become recently more pronounced due to COVID. Also, the GAVI, the Global Alliance for Vaccination. That health partnership is aimed to provide 84 million girls of the low resource region to provide them with best of the health facilities. They are there to provide vaccination to the young women who are denied of the vaccination. So every year around 2.6 lakh women die of cervical cancer and 80 to 85% deaths are from developing countries. So what the Alliance has done? They have changed the balance. They have made the vaccine available to the poorer population, to the developing nations at very lower cost. And the best of the vaccine, they have made it available. We can see the same thing happened with COVID vaccination. They have given the equal rights to all countries for the vaccination. So what does equitable world should look like? What does it should look like? It should look like that all the population have full health potential without barriers or limitations created by social positions to avail the health facilities and to make them equitable, and look equal in all aspects. So basic thing is education, second thing is awareness, and third thing is to economically make them stronger. So this is the equitable word what we are looking for. Creating partnership, making them economically prosperous, innovations, creativity, and giving them hands and making them equal. So what are our goals? The most important goal is educating public about cancer prevention. Many population do not know what is cancer, how to find that, how to diagnose that early. So make them aware that what is cancer, how you can find it in early stages, what can be done. Then second thing is healthcare professional. This is the biggest lacuna what we are finding in our country, like in India. We are lacking in healthcare professional because of our huge population. Equipping cancer healthcare professional with adequate skills and knowledge to recognize the disease early and make them to get the treatment early. That is the best thing which can help the cancer patients. So government should make one good policy and programs. I think PBCR and HBCR are the government policies and programs which are helping to find out more and more cancer patient and bring the data to the central level, so that we will have some data regarding these diseases. Then increasing resources and implementing country-specific programs like what is they are doing in India. So what, as an individual, what we can do? We can raise our voice. We can talk about tobacco, like tobacco should be avoided, tobacco should be stopped production. Alcohol, we should talk about that. We should talk about drug addiction, youth population, youth education, good habits, and diagnosing cancer, and why the delay is there in the treatment, like why the patients come in first stage and they go away, and why that neglect is there in Indian population typically. So what are the cancer barriers? Typically gender. Like I have seen many times that women are reluctant to come for like screening for breast cancer, cervical cancer. Then minority population, they don't know. Then rural urban divide, age discrimination, refugee status, and homophobia. So importantly, this care gap is not only between high and low resource setting. Disparity exists within most countries among different population due to discrimination or assumption that encompass age, cultural context, gender norms, sexual orientation, ethnicity, income, education levels, lifestyle issues, and these factors reduce patient chance of surviving the cancer. If we can reduce the gap or close the gap, lot many lives could be saved, or we can make them accessible with far better facilities than what we are having right now. So this is the crux, and thank you all. Thank you, Manjusha madam. Thank you, IMA. Thank you, RST, for giving me opportunity to talk on such a wonderful topic, and UICC for giving such a theme to all. Thank you all.
Thank you, Dr. Aniruddha.
Thank you, ma'am.
Such a nice talk, and point-wise, everything is illustrated properly and informative talk. I will tell our viewers that this program will be there on YouTube after tomorrow. By the tomorrow, you can watch this program on YouTube also. And we will move to our next agenda, that is panel discussion. Here I invite Dr. Shriram Kane sir, moderator for our panel discussion. Dr. Shriram Kane sir is has done MBBS and MD from GMC Nagpur, and he is hemato-oncologist of the city, senior hemato-oncologist of the city. He is working as honorary consultant in medical oncology department at RST Cancer Hospital since 1987, and he is working as hemato-oncologist at Orange City Hospital in Nagpur, and along with that his own personal private hospital. And over to you, Kane sir.
Thank you. At the outset, let me thank the organizer for giving us this opportunity to talk about the gap and how do we try to close it in our clinics or in the field itself. Today I am fortunate to have a very good panelist with me, and let me introduce my panelist to you. First is Dr. Satyashil Sapre. Hello, Sapre.
Hello, sir.
He is
Am I repeating?
yes. He is a ENT surgeon. He has worked as associate director of RST also, and he has been associated with RST for last 20 years and have a huge experience as far as treating the head and neck surgery. The second panelist is Dr. Prashant Dhoke. He is working as a therapist at RST Cancer Hospital for last 8 years, and again has amassed a huge experience in treating all the solid tumors and hematological tumors there. Then third panelist is Dr. Mayur Gaigavani. He is a gynae oncosurgeon and laparoscopic surgeon who is working at RST Cancer Hospital, and he heads the department of gynae onco surgery at RST Cancer Hospital. Hi, Dr. Mayur.
Okay. Good morning, sir. Good morning, everyone.
Good morning. Then we have a young person, Dr. Mukesh Bang, who is a medical oncologist and has joined recently as a medical oncologist at RST Cancer Hospital. He has done his DNB in medical oncology from Apollo Chennai and has been working in many metro cities, and now has joined as a medical oncologist at RST Cancer Hospital. Hello, Mukesh.
Good morning, sir. Thank you.
Good morning. Good morning.
Good morning, sir. Thank you.
And last but not the least is Dr. Pachel, who has been associated with RST for a very long time. He is an anesthetist and now he is the in charge of ICU and emergency care at RST Cancer Hospital. And he has also a very huge experience for more than 20 years working with patients at RST Cancer Hospital. Today's theme is how do I close the gap while caring the patients? And here we will be talking about our real experiences while interacting with cancer patients. So it's a real world experience and not just the theoretical talk. As we have heard from previous speaker that lots of gap exist between patient and the facility where the treatment care facility is available. So first, let us start with Department of ENT. This is the commonest cancer that we face in our area. And one of the very important predisposing factor is tobacco use. And there has been a lot of campaigns going on to avoid tobacco use. We have very frank labels, warnings on the tobacco packets. You have very scary photos of head and neck cancer on the packets and tobacco packets. Still, we find that a lot of people, the most important predisposing factor remains tobacco. So why this gap and what we have to do? Dr. Sapre, please.
Good morning to everyone. As sir said, I am dealing with the true world, and I am dealing with the patients who are from very poor socioeconomic status. And my concern is that nowadays, since 20 years, the focus has shifted on younger patients who are the breadwinner of the family. So I tell them that if you are going to consume tobacco, you have started a path where your your oral cavity is going to face a lot of problems. I always tell them that cancer is the end of all the sufferings which they are going to have because of tobacco. First, they have submucous fibrosis, then they have leukoplakia, they have burning pain. मैं उनको एक बहुत सही चीज बताता हूँ, मीन्स हाउ आई एम क्लोजिंग द गैप, कि अगर आप ये तंबाकू खाते रहोगे तो दुनिया में जो एंजॉयमेंट के लिए टेस्ट है, neither you can see this patient can nor enjoy tea, nor they can enjoy what we call hot foods like samosa and all that. And moreover, after a few days, they are not able to open mouth. So I always tell them that don't eat tobacco, because you are not only spoiling your money, you are spoiling your enjoyment. And I don't normally I have learned, don't beat about the bush, tell the truth. Many times I listen that by telling the truth, patient may be hurt. But you cannot see, afford to see a patient who is consuming tobacco. He has not been counseled properly, and slowly he is going from bad to worse, and ultimate outcome will be death. So you have to tell them. I do agree that encouragement has to be there, but some truth has to be there. They have to be told. And I have found that since last 3-4 years, if you are a truth and if you are trying to tell them that this is the outcome, they listen, and this is how I'm trying to close the gap, because I have realized that 99% of the patients or their families don't know ABCD about cancer. And cancer cannot be compared to benign disease. I always tell that if you got a discharge from here, you can live for 80 years. You cannot live with cancer for many years. So this is how I try to close the gap. And I tell them that please leave the tobacco.
Yes, thank you. A point is very well taken. Unfortunately, the head and neck cancers that we see, they are in very younger patients, and they are the breadwinners. And it's really heartening to see that young boys in 20s and 30s presenting with head and neck cancers, and the underlying predisposing factor remains the kharra chewing and other tobacco products. Radiotherapy plays a very big role in treatment of cancer, and one of the capital intensive establishment is the establishment of a radiotherapy center. The availability of radiotherapy centers has been a big problem in India, and probably of late we are seeing many more centers coming up. So I would go to Dr. Prashant. So how do we try to close the gap between the radiotherapy availability and the patients in the societies?
Good morning, sir, and good morning, everybody. So the question is this availability of centers. So, sir, presently there are not enough radiotherapy centers available. At some places, the radiotherapy centers are available, definitely, but the burden of the patient at these centers is too high. So let me explain that brachytherapy is available only at our center. Total Vidarbha, there is only one brachytherapy center catering to all these patients. Monthly, near about 90 to 100 brachytherapy patients we are catering. So, in my opinion, the government policy should be focused that every district have all that external beam radiotherapy as well as the brachytherapy centers. As we see that in Nagpur, there are only 2 government setups. Now the AIMS third setup is there installed. So the burden of the total patient is more at these centers. And also want to explain that some private centers are also there. But what happens, the cost of the treatment is too high at the private centers. So government policy should be such a like that more centers should be there. Every district should have one center, that complete center in the sense external beam radiotherapy as well as brachytherapy should be there.
Yeah, yes, we need to improve the availability of radiotherapy center, because that seems to be a very major factor in establishing the complete cancer care centers, which can cater to all the problems in the field of cancer, and all the treatment will be available at under one roof. So radiotherapy centers, we need to increase the numbers quite drastically. Then we come to the gynic cancers. As Dr. Wagh has said, the cervical cancer remains a problem. And this has been a problem in our areas, especially in rural areas. The cervical cancer remains a major problem. We have a very simple test, the pap smear test, which can detect this cancer very early and patients can be cured. But still, we find that the number of cases that we see in late stages is really astounding. So there seems to be a big gap. So we have a good screening test available, and still patients are coming quite late as far as the cervical cancer is concerned. So I'll ask Mayur, so what do you think about this gap and how do we go about it?
As you rightly said, CA cervix is a second most common cancer in India and in world. About 97,000 women dies of CA cervix in India. There is a test for screening. Only only cancer in human body where screening method is available is cancer cervix. Okay, and we have this pap smear test, which is an age-old test since decades, but we have not reached to the masses. No. So how can you reach to the masses? So only by educating people who can reach to the masses. In Bangalore city, there was a study 10 to 15 years back, and 80% of the women don't know about this disease. Forget about the pap smear test. So there is very little less education about the cancer and prevention of the cancer. So by educating patient or educating people who can reach to the masses, and who can do more and more pap smear tests. How to educate people? First, we can do various camps, like all cancer hospitals do camps to the rural in rural areas. Second is there should be a dedicated cancer prevention clinic, so that people will come and do pap smear test and other preventive tests. And third is mass media campaign. We have mass media campaign for tobacco and other cancer, but we don't have mass media campaign for this uh, cancer service, and which is second most common cancer in India in women. In Australia, they have started this mass media campaign, and they are doing pap smear test for every woman every 3 yearly. Not just gynecologist, but pap smear test is done in Australia by uh, nurses also, by trained person also. And due to this by educating people and due to this mass media campaign, they have reduced the number of cancer deaths. Second, they have prevented the cancer cervix, and uh, diagnosing patient at they are diagnosing patient at early stage. We are getting cancer cervix at later stage, but in Western world, in Australia, where we get cancer patients at early stage, and the survivability of the patient at early stage is better.
Yeah, thank you, Mayur. You have raised a very good point that we need to have a better focus on cancer preventive clinic. Not only treatment clinics, but preventive clinics should also form a major component in cancer care centers. We have seen a great changes in the treatment of cancers over the last few decades, and chemotherapy has played a great role in changing the overall scenario as far as the treatment of cancer is concerned. Basically, cancer treatment remains a multimodality treatment which involves surgeon, the radiotherapist, and now more and more frequently, and playing a more and more prominent role is the role of a medical oncologist. So, and we have seen a lot of targeted agents coming up recently in last decade, and now every 6 months, not 6 months, why 6 months? Every month we find something new coming up as far as the targeted agents and newer drugs are concerned. So I'll come to Dr. Mukesh. So what is the exact role of chemotherapy in overall management of cancer as on today?
Good morning, sir. I thank all the organizers, including IMA. This is the most important part in cancer management. As everyone knows, if anyone says it's a cancer, they are not worried about cancer many times. They are worried what is the stage and whether I will need a chemotherapy or not. This is the question every time this patients and family ask, because chemotherapy, these are the cytotoxic drugs which try to kill the fast multiplying cells. The main important fast multiplying cells are the cancer cells. So those get affected by the chemotherapy. Chemotherapy has a big role. 80 to 90% of the cancer care patients, they take chemotherapy because it has multiple roles. It comes as adjuvant chemotherapy part, where we give the chemotherapy once we operate for some patient that we have some colon cancer, breast cancer. After that, there is a chance of recurrence or micrometastasis. There we give chemotherapy to them. These are the chemical drugs which try to kill the cells. After that, we have a role in neoadjuvant. That is the term used as a neoadjuvant chemotherapy. Neoadjuvant means the definitive therapy may be surgery or radiation, but here the tumor volume is big, like a 7 centimeter, 8 centimeter breast mass or any other mass. The surgically, which is very difficult to take it out. So where we give chemotherapy, we try to shrink the tumor and then hand over to the surgeon and radiation team so that they can go for the definitive therapy. Third part is a palliative chemotherapy, where we treat patients with stage 4 disease, where they are not for definitive therapy like surgery, radiation, where we try to control the disease with maintaining good quality of life. Your question was like, as we go day by day, we are going more and more towards targeted therapy, immunotherapy, because we know at the terminal stage, like stage 4 situation, the chemotherapy has plus and minuses. Just like chemotherapy, they try to kill the cancer cells, they try to act on the fast multiplying cells of our body, like the bone marrow cells, hair cells, mouth mucosa cells, the sperm count, the ovarian ovums, and the intestinal cells. So automatically, when we give chemotherapy to this patient, they will get some or the other these side effects. But with the targeted therapy, the side effect profile is going less and less, and we are trying to go, as the research is going on, we are trying to search the molecular profiling of each cancers and try to target by individual targeted drugs and immunotherapy, so that we'll have a good quality of life for the patient and good control of the disease even in advanced stage. Now I can say, like drugs like trastuzumab, imatinib, they have changed the treatment modality in cancers. Previously leukemia, a deadly disease, but CML, now we have imatinib, which can, just like a diabetes, you just have to take the tablet and you are absolutely fine. Trastuzumab, a big role in breast cancer. So these are already approved by FDA, and everyone is using since last 20-25 years. So I think chemotherapy plays a big role, and definitely people should not be hesitant about chemotherapy. They should come and they should take it there, and they will have a good chance of survival, or with good quality of life, we can continue with the chemotherapy in advanced stage also.
Yes, I agree. And there was a phase where we were heading for more and more stronger chemotherapy, and now the more and more aggressive as far as the chemotherapy is concerned. Now gradually we are shifting towards a targeted therapy where we try to give good control of disease as far as, and also the good quality of life. Then there is a definite role of ICU in overall cancer management. ICU does not mean terminal care here. But ICU has a many huge role to play in giving proper treatment of cancer to these patients. So I will go straight away to Dr. Patel. Just explain how that ICU plays, what role exactly ICU plays in overall management of cancers.
Good morning. Hello. Hello.
Good morning.
Am I audible?
Yes, yes,
Hello?
yes. You are audible.
Okay, okay. Good morning, everybody. So today I'm going to highlight the role of ICU in a case of cancer patients management. So this is a very well-known fact that approximate 50 to 60% of the cancer patients definitely in need of ICU support during their journey of cancer treatment. In our ICU, basically, we are dealing with 3 types of patients. Type 1 patients are post-operative patients. Like we have got our all 3 departments, surgical oncology.
Not audible.
Not audible, not audible. You have muted your mic, unmute it. Unmute your mic, yeah. No, again it is muted.
Am I audible?
Yeah, yeah. Now you are audible.
Okay. Approximate 50 to 60% of the cancer patients need ICU support during their journey of a cancer treatment. In our ICU, basically, we are dealing with the 3 types of main patients. Number 1, first type of patients are the post-operative patients. Like in surgical oncology, our surgeons doing esophageal surgery, GI surgery, and head and neck department, we are doing PMMC flap as well as mandibulectomy. Gynic department, we are dealing with the ovarian malignancy as well as Vardaim cystectomy for cancer cervix and endometrial malignancy. So all these patients need post-operative care. So in our ICU, the first type of patients came for the observation as well as ICU management. Due to side effects, hello.
Hello, yeah.
Hello. Then second
yes.
after complication because of the treatment. In case of aggressive chemotherapy, like in the medical oncology department, patients of leukemia and lymphoma, they come with tumor lysis syndromes. Then post chemotherapy, we are managing febrile neutropenia, sepsis, severe metabolic disorder like electrolytes imbalance, hypophosphatemia, hyperlipidemia, hypercalcemia. All these patients came to our ICU for the sake of management. The complication of radiotherapy like severe mucositis, radiation-induced diarrhea, severe anemia, pancytopenia, all these patients also came to our ICU for the sake of management. From surgical side, we are getting the patient of stridor, superior vena cava obstruction syndrome, massive bleeding from the disease sites. Most important is that these patients can be very well reviewed and managed if treated properly, having a very good result. So the second type of patients are very much important for our ICU because these patients will be cured at most if suppose treated properly. And the third type of patient what we are getting in our ICU are the terminal cancer patients having multiple parenchymal metastasis like liver mets, lung mets. So these type of patients in our ICU came for the sake of just support to treatment and management. So our ICU basically manage these 3 type of patients. Hello.
Ani sir, please unmute yourself.
Yes, now I'm in. Yeah, so ICU plays a very important role, especially in post-operative management also. And now we come to ENT person again. There are many problems regarding after you have planned for a surgery for head and neck patients, because these surgeries are quite extensive, they are mutilating. So how do you approach to a patient to convince him that this is the one of the best approach for you, even it causes lot of mutilation and other problems? So this must be a big problem. How do you close this gap?
As I said, there is a difference between the management of cancer patient and benign disease. I tell them in the very beginning that the aim of the treatment is to save life. Cancer poses a problem to your life itself. So I tell them that please go for treatment, because if you are going to be alive, then there comes the question of cosmesis. Then there the questions whether I am going to look nice or not, my organs will be working or not. And then I tell them, as it has been shown, that there are many VIP personalities who are very prominent in the field. When they have gone for treatment, when they have gone for head and neck treatment, where their face may have been deformed, their functions may have been deformed, but they are alive. So I convince them that go for aim of the treatment is to save life.
There is some problem in networking.
Suppressor can close his video, stop his video, and then
Yes,
talk
there
alone.
is some problem in network. So please stop your video and just keep your mic on. Anyway, we'll go ahead. So the point is very well taken. The saving life is of prime importance, rather than to have some deformity or some problems following the cancer treatment. So saving life remains the most important thing. Again, another field is radiation field, and there are many myths and misconceptions about radiation in overall population. The treatment duration as far as the radiation concern is quite long and can be quite troublesome. So we find actually in working in field, these are the big gaps that we have to face. So I'll go to Dr. Prashant. So how do we try to close this gap as far as the conceptions and misconceptions about radiotherapy is concerned?
Right, sir. The main problem of radiotherapy treatment is we have to explain every patient the duration of the treatment, because once radiation started, it's long for near about 1.5 months, near about 35 settings, 25 settings, or 30 settings, depending upon the cancer, the head and neck cancer, post-op patient, cervix patient, breast patient. So near about 1 month treatment is there, that is daily radiation to be taken. So first we have to convince the patient the necessity of the treatment. So first step is we convince the patient the duration of the treatment is absolutely that is required, or it is the must, or it is the most important part, that we have to complete the treatments to avoid the recurrence. So most of the energy we have to spend on to convince the patient that it is absolutely necessary treatment, and this much of treatment should be taken compulsorily. So there are much more that is myths, that is मेरा पूरा शरीर काला पड़ जाएगा, मुझे जलाया जाएगा, या मेरे शरीर के सारे बाल चले जाएंगे, या फिर मुझे बहुत गर्म लगेगा, समथिंग। ये कई प्रकार के इन लोगों में ये मिथ्स होते हैं। तो हमें इन पे ये पूरा उनको पहले एक्सप्लेन करना पड़ता है कि अगर आपको कोई भी तकलीफ होती है तो हम लोग यहाँ 24/7 यहाँ आपके लिए अवेलेबल है। तो ये जो इनको हम बताते हैं कि जैसे सिटी स्कैन या एमआरआई स्कैन होता है, उसी प्रकार की मशीनें होती है। जैसे सिटी स्कैन करते समय अपने को कोई तकलीफ नहीं होती, उसी प्रकार से ये रेडिएशन भी होता है, और उसी प्रकार हमको डेली आना होता है। हाँ, डेफिनेटली कुछ ट्रीटमेंट होने के बाद में थोड़ी सी तकलीफें जरूर होती है कि जैसे कुछ म्यूकोसाइटिस है और लूज मोशंस वगैरह है, लेकिन ये सारे जो साइड इफेक्ट्स है ये हम इजीली आसानी से ट्रीट कर सकते हैं। विदाउट एनी डिस्टर्बेंसेस वी कैन कंप्लीट द ट्रीटमेंट। हम पेशेंट को यही बातें सब समझाते हैं। ये मेनली इस वजह से होता है, ना ही पेशेंट को इस बारे में पता होता है कि रेडिएशन होता क्या है। तो हमें इस बात पे ध्यान देना पड़ेगा, अवेयरनेस हमें इस बात की बढ़ानी पड़ेगी कि रेडिएशन इज बहुत महत्वपूर्ण पार्ट है अपने ट्रीटमेंट का। ये पेशेंट लोगों को हमें समझाना पड़ेगा कि जैसे सर्जरी एक महत्वपूर्ण भाग है, कीमोथेरेपी महत्वपूर्ण भाग है, उसी प्रकार से रेडियोथेरेपी भी उतना ही महत्वपूर्ण भाग है। इससे थोड़ा बहुत साइड इफेक्ट जरूर होता है, लेकिन ये हमें ठीक होने के लिए आवश्यक है। तो हम इसी बात पे ज्यादा फोकस करते हैं कि पेशेंट को काउंसलिंग करते हैं कि ये इंटीग्रल पार्ट है, जरूरी पार्ट है।
Proper counseling plays a big role, both as far as the ENT person is concerned, as far as the radiotherapy is concerned. It's not, sometimes we do see a patient who are dead against taking radiation. They say, let anything happen, but I will not go for radiation. And it's really a big task to convince a patient that, yes, that is the best thing which is available for you at this moment, and one should go ahead with it. As it is said that saving life is of prime importance. Then we'll come to gynecologist again. When patient has any symptoms, the patient would approach to the local gynecologist as a first contact with the patient. So the gynecologist in society play a very important role as far as the closing this gap between the patient and the cancer facility. So what would you talk about the role of local gynecologist as far as closing this gap is concerned?
Thank you, sir. Actually, local gynecologists are the primary physicians for most of the women, and all women go to some gynecologist at least once in a lifetime for her obstetrics or her gynec problem. So whenever they go to the gynecologist should always treat the disease and also talk about the preventive approach of the cancer. What are the types of the cancer and what are the management of the cancer, so that they become more receptive to this cancer treatment. And they should talk about the screening or pap smear screening. Like pap smear is done after 30 years, every 3 yearly till age 70 years. This is one screening. Another screening method for CA cervix is Hpv Dna testing. We can combine Hpv Dna testing with pap smear also. Then if there is any abnormality in Hpv Dna testing and pap smear, then we can go for colposcopy. And if there is abnormality in colposcopy, you can go for biopsy. Pap smear and is generally available at many places, but colposcopy is not available at many places. So they can refer where the colposcopy is done. Then this is about the preventive. Then about diagnosis of the cancer. Symptoms of the cancer are very vague. Okay, they many benign gynecological conditions has the same symptoms like pain in abdomen, white discharge, or bleeding PV. So whenever there is whenever they come with these symptoms, then proper gynecological examination and proper testing need to be done. Like many of the Indian women, they are shy. So whenever they go to gynecologist, they are hesitant about the pelvic examination, but they should do pelvic examination also. And with that, we can diagnose cancer cervix at early stage. Another thing is we should have whenever there is pain in lower abdomen, so we should have low threshold for sonography diagnosis also, because many of the time we get cancer ovary at late stage. So and patient is suffering from pain in abdomen since last 6 months. So when the patient comes to us is third, most of the time is third stage. So for local gynecologists, they should have low threshold for sonography also, so that we can diagnose ovary case at early stage. And whenever there is a diagnosis, then they can refer patient to a cancer hospital where there is holistic approach, multidisciplinary and comprehensive approach is there. There was one study cancer patient whether a gynecologist should treat or gynec oncosurgeon should treat this thing. But it has seen that with gynec oncosurgeon, if he performs surgery, life expectancy by 10 months. Difficult cases, they should send to a cancer center, and you can prolong the survival rate. Thank you.
Yes, the role of local physician or local gynecologist is very important, and a timely referral to a tertiary care centers does improve overall survival and overall outcome as far as the treatment is concerned. So now I will come to Dr. Mukesh. Chemotherapy comes with a lot of baggage. I would say that there are a lot of myths and misconceptions about chemotherapy. I remember when I started giving chemotherapy, patient used to come to my clinic and watch everywhere. So what horrible things are going on here? If everything is fine, and then that patient would come to me for chemotherapy. Now these things have a bit changed, but still there are a lot of myths and myths about chemotherapy in overall population, and people are still afraid of going ahead with chemotherapy. So this is a big gap, I would say, that between the cancer patient and the proper treatment. So what's your opinion and how do you overcome it?
I think in the close the care gap, the most important part is the chemotherapy component, because it comes with the cost and it comes with the side effects. Because the drug cost and the side effect cost, most of the patient, they come to us, sir, we will go ahead with surgery, we'll go ahead with radiation, but we will not take chemotherapy. But then I tell them, because thanks to Bollywood people who are advertising and they are showing that chemotherapy, how it works. I think those are the examples which I give, not to enumerate in the right now, but there are so many Bollywood cricketers, and they have given advertisement that how the chemotherapy works and how the patient care is there. So after that, I think many of the people now, they have started taking chemotherapy, because it always carries a burden for the medical oncologist also and for the patients also. I always tell them there is the cells are very toxic cells. They multiply in millions, within minutes, hours, and everything. So we need to give the drug which is that fast acting to treat these cells. So definitely when we treat these cells, we are not treating something like a viral fever or something, some viral infection, something. We are treating a very deadly disease. And when we treat this, we should have the drug which is as powerful as the disease. So definitely when we use this, there will be side effects, but these are all reversible side effects, most of them. Just like people, we know in India, if you say the females, if they have breast cancer, if we tell them, sir, I will not take chemotherapy because my hairs will go and now I will not come. So I always tell them, see, for you, the priority is your health. And if you are fine, then hairs can grow back. Once you stop chemotherapy, after 3 months, 6 months, your hairs will come. Your mucosa will be okay. You will be fine. But right now, we have to fight the disease, because these drugs are used to control the systemic recurrences and to give control over the disease. And that's the reason these drugs are important. And I always tell them, see, this Hollywood, Bollywood, everyone who are like projected persons to see and just to follow. Even if they are taking, that means they are too much worried about their looks and everything, but still they are taking they don't have hairs in between when they took chemotherapy, but they have advertised and they have given. So I think after this, I think really we should thank these people who has really helped us in counseling these patients about chemotherapy. Definitely side effects will be there. We take those burden with us, but there are so many advances, like just like for nausea, vomiting, which happens with chemotherapy. We have newer and newer drugs. We have drugs for the bone marrow suppressions. We have drugs for everything. So I think we nowadays we take much more care about because we have drugs available. But few years before, the drugs were not available. So now we have more and more drugs available. So I think I counsel like that only. Just see the people who are the focus of attraction and still they are using therapies. So that means what is the importance of these drugs? And definitely the chemotherapy works in all stages, and some curable diseases, just like Hodgkin's lymphoma, leukemia, choriocarcinoma, seminoma, they are completely curable with the chemotherapy. So definitely chemotherapy has a big role in cancer care. And to close the care gap, the most important part, I feel, and not being a medical oncologist, I feel the knowledge about importance of chemotherapy, how it works, how we can reduce the side effect, and we have drugs available, and the cost. Now we have so many schemes in RST. We know we treat so many patients, a huge load of the cancer patients, and we treat so many patients with chemotherapy in the Yojana, where they take free of cost. And cost is definitely a big burden. And now government is giving policies, Yojanas, and everything. So now I think from what I think 20 years before, now people are at least they understand, they know they are slightly feared, but they take the chemotherapy. And I think we should take it forward. I am trying to project more for the molecular profiling and try to give more and more of targeted drugs and immunotherapies, which can decrease the side effects of the chemotherapy, and we can prolong the life of the patients in stage 4 disease also. Now we have so many targeted drugs. Previously, if the patient is having breast cancer, lung cancer, the survival was 6 months, 8 months, 10 months, 12 months, we used to tell. Now we have so many targeted drugs. In lung cancer, we have EGFR targeted drugs, molecular targeted drugs, which we can give the patient they just take like a diabetes, they take the tablet after 1 or 2 years, 3 years. You don't, patient don't feel also that he is a cancer patient. People don't recognize, oh, this patient is having a stage 4 cancer. But the molecular advances, the chemotherapy advances, the newer drugs in the pipeline, so they have given a really too much benefit to the cancer patients, and we are trying to project that more and more.
Yes, so ultimately it boils down to the counseling, and
yes,
it's good that Bollywood is playing good role here also.
Yes,
and it's really good to see the cancer survivors from Bollywood coming to the various TV shows. So
yes,
that gives us really a convincing power.
It has helped us, sir. Actually, few of my patients, they used to tell, sir, we will not take. I used to tell them the names of this. See, you have seen these people. They have taken the therapy. They are the figures which people follow and see.
Yes, yes.
If they take the chemotherapy, that means you should understand what is the importance of chemotherapy, and you should always take it.
You are
if it is
forgetting
required.
cricketers also.
No, cricketers I told, sir. Cricketers also I told, but I don't want to name anyone, so that's the reason I told cricketers and Bollywood. Both I have told.
Yes, and then because of various schemes, the chemotherapy has become available to a very low socio-economic group also, and then we are getting good results out of simple standard chemotherapy in advanced, even in advanced diseases.
Yes. So in RST, every day we give at least 50 to 60 patients chemotherapy under Yojana. That's a big volume, big number which we give. So people are taking and they are still fine, they are taking. So I think that's a very good thing. And I think as the time goes, we'll close this more and more gap with the cost and counseling, importance of therapy.
Yes, yes. Basically sticking to a low cost, basic, effective chemotherapy now has become a norm as far as the Yojanas are concerned, and then we are getting good results out of it. Then ultimately, breaking a bad news to the patient is a very difficult task. And then there are lots of gaps that remain in communicating to the patient and the caregiver. And I think Dr. Pachel is the best person to elaborate more on it, because he's doing this day in and day out in his ICU. So Dr. Pachel, over to you. Please unmute your mic.
हेलो
yeah,
सर, आप मुझे सुन सक रहे हो?
हाँ जी,
यस सर। हाँ, बेसिकली सर, ब्रेकिंग द बैड न्यूज ये सब में बड़ा और इम्पोर्टेंट टास्क है एक आईसीयू और एक इंटेंसिविस्ट के लिए, जो हम रूटीनली फेस करते हैं। अपने पिछले 25 साल के करियर के दौरान आईसीयू में मैंने ऐसे काफी केसेस फेस किए जहां हम लोगों को डेथ डिक्लेयर करना पड़ता है। बेसिकली बैड न्यूज का जो डेफिनेशन दिया है WHO ने, दैट इज इंफॉर्मेशन दैट ड्रास्टिकली अल्टर द लाइफ वर्ल्ड ऑफ अ पेशेंट इज टर्म्ड एज द बैड न्यूज। बैड न्यूज बेसिकली दो प्रकार से रहती है। पहली तो ऐसा कि जिस वक्त पेशेंट डायग्नोस होता है, उसको फर्स्ट टाइम पता चलता है कि उसको कैंसर है, उस टाइम पर हमको जिस तरीके से उसे बताना रहता है या उसके रिलेटिव को गाइड करना रहता है कि भाई आपके पेशेंट को कैंसर है, वो एक प्रकार की पहली बैड न्यूज रहती है। और दूसरी जो आईसीयू में हम लोग बैड न्यूज ब्रेक करते हैं, वो रहता है इधर पेशेंट बहुत ही क्रिटिकल है, सीरियस है, या फिर पेशेंट का डेथ हो गया है। उस टाइम पे पेशेंट के रिलेटिव का जिस तरीके से काउंसलिंग करना पड़ता है, वो रियली एक इंटेंसिविस्ट के लिए बहुत ही ज्यादा स्किलफुल जॉब है। तो मुझे ऐसा लगता है कि इसके लिए हमको काफी ट्रेनिंग की और काफी एक्सपीरियंस की जरूरत गिरती है। और जब हमारे आईसीयू में ऐसे पेशेंट आते हैं जो टर्मिनली इल रहते हैं, खास करके ऑर्गन मेटास्टेसिस के साथ में लिवर मेट्स, लंग मेट्स, जहां पर हम लोग सचमुच एक पैलिएटिव केयर के अलावा उसको कुछ भी सपोर्ट नहीं दे सकते हैं, इस टाइम पे जब पेशेंट के रिलेटिव हमसे मिलते हैं तो हम उनका रिपीटेडली काउंसलिंग करते हैं। और काउंसलिंग भी फुल पारदर्शिता के साथ में होता है पेशेंट्स के रिलेटिव का, ताकि वो सब चीजों को समझ सके। और उनको बार बार ये बता के उनको माइंड सेटअप के साथ एक्सेप्ट करवाना पड़ता है कि शायद आपका पेशेंट कुछ समय का या कुछ दिन का मेहमान है, या फिर आपके पेशेंट का कुछ समय बाद डेथ होने वाला है। तो जब धीरे धीरे हम पेशेंट्स के रिलेटिव को ये बात उनके माइंड में बिठाते, तभी कहीं जाकर वो इस बात को समझते। बेसिकली होता है कि जब टर्मिनल कैंसर पेशेंट आईसीयू में आता है, उस वक्त सब में बड़ा प्रॉब्लम ये होता है कि 2-3 साल से ट्रीटमेंट लेते रहता है पेशेंट, और उस वक्त तक उसको सोशली, इकोनॉमिकली, मेंटली बहुत सारे प्रॉब्लम उसको और उसके खुद के रिलेटिव भी आ जाते हैं। और वो सारे प्रॉब्लम की जो भड़ास रहती है पेशेंट के रिलेटिव की, वो अल्टीमेटली जब पेशेंट का डेथ डिक्लेयर किया जाता है, तो वो एक जो बेचारा डॉक्टर रहता है आईसीयू का, उसके ऊपर बहुत बुरी तरीके से निकलती है। इसीलिए आईसीयू के डॉक्टर को बहुत ही बेहतरीन तरीके से उनका काउंसलिंग करके और पारदर्शिता के साथ में उनको समझाकर बैड न्यूज को ब्रेक करना पड़ता है। रियली एक बहुत ही स्किलफुल प्रोसीजर है। और अभी तो एक्सपीरियंस के मुताबिक हम लोगों ने आईसीयू में काफी एक राइटिंग वर्क करवाते हैं, पेशेंट के रिलेटिव का साइन लेते हैं। इस तरीके से हम लोग न्यूज को ब्रेक करते हैं, ताकि पेशेंट के रिलेटिव बहुत ज्यादा एग्रेसिव ना हो और आईसीयू में या आईसीयू के किसी वर्कर के साथ किसी किस्म की अनहोनी ना हो। थैंक यू सर।
Yeah, that remains a big problem, and I think IMA is doing quite a good job as far as avoiding these incidences are concerned. Madam, we are right in time, so I have some time for one round, and I will ask each one of you to give your opinion in just 1 or 2 sentences each. How do we close this gap? Dr. Sapre.
Counseling, and counseling. I think that is required everywhere. And we need to hire more counselors. We see that counseling is very important in foreign countries. So my suggestion is, we have got skill, we have got all resources from doctor side, and if they want to reach very safely to the patient, we need lot of counselors. That is how we can close the gap. That is what I will request. That is what I want.
Okay.
Sir, actually, I also want to explain that the main part is the counseling, because counseling plays a role to explain the disease, treatment, outcome. So I will focus mostly, or there should be a proper counseling.
Mayur.
I think mass media is very important, and government should consider mass media for educating women about the cancer and cancer treatment.
Mukesh.
For me, I think being a medical oncologist, cost is most important because some of the drugs which don't come in Yojana, people have to pay, and then so cost. Counseling definitely plays a very big role, as already people have told. And third is giving the examples of role models which have taken therapies, anyone, so that to counsel them. And most important among this is family. The family support, importance of family supportive system, which can close this gap, because during this treatment, during this therapy, many of these patients gets mentally disturbed. They don't come up because of the side effect or whatever. They don't come up. The family support, the relative support is very important. Those people also can close this gap. It's not only the doctor who can close this gap. Everyone, from social workers, from doctors to family members, patient itself, all multidisciplinary team, everyone comes. I think they can close this gap.
Dr. Patel.
सर कैंसर पेशेंट्स के लिए और सोसाइटी के लिए कैंसर एजुकेशन बहुत ज्यादा जरूरी है। हम जितना ज्यादा से ज्यादा इसका प्रचार और प्रसार करेंगे ताकि हम लोग अर्ली डिटेक्ट कर सके पेशेंट को, ऐसी स्थिति में पेशेंट हम लोगों के पास जल्दी से जल्दी आएगा और उसका ट्रीटमेंट जल्दी से जल्दी शुरू होगा। तो पेशेंट को, रिलेटिव को और सोसाइटी को कैंसर के बारे में ज्यादा से ज्यादा एजुकेट करना हम लोगों के लिए बहुत ज्यादा जरूरी है। थैंक यू सर।
So we'll go back to Bollywood theme again. So what makes the picture successful? Entertainment, entertainment, entertainment. So how do we close the gap? Counseling, counseling, and counseling. Thank you. Thank you. I thank all my
Thank you.
all my panelists, and I thank you, Dr. Manjusha, for giving us this opportunity. Thank you.
Madam.
Thank you, Kane sir. Thank you, everyone. Thank you.
Very, very nice and enlightening panel discussion. And one thing I will tell कि अगर हमें कोई bad news देनी है, जैसे कैंसर है, कैंसर सुनते ही लोगों का दिमाग चकरा जाता है कि अब कैंसर है, अब क्या होगा। तो what I will say कि हम कहेंगे भगवान ने कैंसर का डायग्नोसिस तो भी करवाया है, सीवियर हार्ट अटैक आता तो क्या करते। वहां पे आधी चीज रुक जाती है, वहां पे आधी एंजाइटी कम हो जाती है, और उसके बाद प्लान बी क्या है उस पे काम करो, सो दैट यू विल लिव प्रॉपर लाइफ और वेल लाइफ। सो हियर वी क्लोज अवर CME. I request Mr. Piyush to show mementos. Piyush, we want to felicitate our panelists, our faculties. Our organizers. Mr. Piyush. Mr. Piyush?
Yes, ma'am.
Yes. What I will say कि we cannot direct the wind. हम हवा को तो बदल नहीं सकते, लेकिन we can adjust our sails. हमारी नौका किधर लेके जानी है वो हम देख सकते हैं, या हम चेंज कर सकते हैं. We should not give up. Any question from chat box? Till then, there are no questions. There was one question and Dr. Bang replied to that question.
Question answer.
I think some communication gap is occurring. So let's.
No, he is sharing his PPT. It's taking some time.
Okay.
Ma'am, do you need a PPT to be shared?
Yeah.
Which one?
Felicitation, mementos ka.
It's not a PPT. Okay.
Okay. We are waiting for mementos. Yeah, we would like to felicitate Dr. Kartar Singh sir for joining hands with IMA for this wonderful CME. Then Dr. BK Sharma sir for organizing all the CMEs in past, and for future also we are saying thank you to sir. Dr. Krishna Sarmanwar sir, Additional Director of RST. Dr. Manisha Dhut madam, today's MMC observer, we want to felicitate you madam. Kindly accept our felicitation. Dr. R.B. Randive sir for giving a nice lecture. Kindly accept our felicitation sir. Dr. Aniruddha Vag for lucid presentation, informative lecture. We want to felicitate you sir. Dr. Shriram Kane sir, nicely moderated session, touched each and every points of close the care gaps. Dr. Mukesh Bang sir, we will remember Bollywood and Hollywood examples which you have quoted. Dr. Sachil Sapre sir, thank you for clearing all the doubts of our panel, our audience.
Thanks, madam.
Dr. Prashant Doke sir, kindly accept our felicitation.
Thank you, ma'am.
Dr. Daigavani sir, we will remember the patient are hesitant for their investigation, so we will try to close the gap and ask each and every known person to get diagnosed or get screened for cancers.
Thank you, ma'am.
Dr. Patel sir, a big
Thank you,
work
madam.
by you. Thank you, sir. Thank you. Kindly accept our felicitation. And we are thankful to DigiShield team, our media partner, and RST staff, Ms. Dipti, Dr. Rahul, and all the technical staff given by IMA and RST. Here I say we conclude our CME with a note of thanks. Thank you all. Thank you.
Thank you, madam. Thank you very much.
Thank
Thank you, IMA team. Thank you. Thank you, everyone.
Thank you all.
Thank you, all the organizers.
Dr. Manjugiri and
all
Dr.
the
BK Sharma sir.
We are very much
Thank you,
thankful.
all the participants and faculties.
Thank you to audience also. They have attended in large numbers. Thank you all.
Thank you all.
Thank you all. Now we can conclude our CME over here. Piyush, please stop recording.